work. Hi, friends. Hello, friends.
Hello from the North Coast.
North Coast. Where does that come from?
Well, that is, I'm realizing I should have maybe have said Northwest. It's Northern California, the coast in Northern
Oh
California.
yeah, I'm like, wait a minute. I'm like, my parents live in Maine.
Yes, that is the true North Coast.
That is also North Coast, especially in its weird little like trickling up there above the parallel way.
Yeah.
Trying to follow like inlets and riverways the way it does. Um, Hi, everybody. We are doing so much work right now. Holy moly, I see so many longtime gravity friends. I feel like, Lucy, I've seen you half of my week in some meeting or another. Just really impressive work the gravity community is doing on all fronts right now. Um, some of you I've seen like multiple hours today in various different work groups and various different projects, and just friends, well done. Hi, I'm talking informally. Um, I'm Sarah DeSilvi. This is the November 14th Gravity Public Terminology Call. You are in the right place. This is the last end-to-end review of our language barriers and incarceration status concepts. We are really glad that you're here. And we will start at approximately 1 minute. And looking forward to reviewing things today. Not very much new, a couple placeholders for new concepts that our SMEs are working on. Nice to see friends here.
Hey, Sarah, this is Susan Matney.
Hi, hello.
So I'm new.
I
So
know. Welcome. Yeah, how exciting.
thank you.
All right, I think, yeah, I want to talk to you, Susan. Let's connect offline because I would love to connect with you on what we were last talking about at the LINC conference.
Okay.
All right, I think it's close to time. All right, we're just going to give it 1 more minute. Hello. I can't hear you. I think you're muted.
Oh, I was just gonna say that you do a great job. I don't know how you do it, but you do a great job.
Aw, thanks. It helps when the community is so lovely.
No, and it's very much needed. The way I don't, we're underestimating right now the amount of work we need to do at the grassroots level. And I don't see that people are even ready or are even thinking in these terms that how these institutions need to be connected and what would it take to get them connected.
Yeah.
So, long,
Yeah.
long, long time ago, when I was in the IT department, I did program HL7 files. So I know what it takes and I know the worth.
Yeah, and this is partly why, again, like, a long-time gravity principle has been borrowing the definitions that exist in social care entities and services and regulations from across the human services world to enable that integration, right? So like bringing that knowledge in. So hopefully,
Absolutely. It's
nice.
extremely important. And in fact, I was actually thinking on not really related to the work that you guys are doing, but supplementing to this work in the grassroots that the definitions that are being designed and defined here should be adopted as a norm at the grassroots levels too. And I don't see anybody doing that. So I was actually thinking of literally creating a glossary and putting it out there saying that, listen, this is what it means. When you say language proficiency, this is what it means.
Oh, great. Yeah,
Or
we would love to collaborate on that because we have friends that, across each of these different domains that are working on that. The same thing's been like referenced regarding our incarceration status concepts and research. Like that was one of the like one of the amazing capabilities that we realized we had. So looking forward, happy to connect offline on that. And again, that's part of our hope as well.
thank you.
All right. So with no further ado, Christy, hi. We're going to kick off our end-to-end review of language barriers and incarceration status. Thank you all for coming. Again, we're having an early vote because of the Thanksgiving holiday. So, and our need to try or attempt to try to finish our domain work before the due date for IC10 CM submission. So, again, much of this content is known to you. Thank you for coming. And here we go. Next slide. Welcome all newcomers. Welcome, that's the next slide. Welcome. Thanks for joining the Gravity Project. Oh, sorry, if we go back just one slide, I do have to go through the formalities. Thank you for joining Gravity Project Terminology Community Meeting. We mute individuals upon entry, but this is we call it a formal process, but informal meetings because we really try to aim at consensus. So feel free to raise your hand or ask questions as we go along. All calls are recorded. Recordings are always available on the Gravity Confluence page following. We really do encourage use of the chat. So you can go into, type chats to everybody, and we'll try to make sure those concepts are integrated as we go along. So again, thanks so much. Please send chats to everybody, and anything sent to me, I always say I read out loud. So don't send me anything you don't want read out loud because it's hard for me to filter what I'm trying to facilitate. Next slide. We have the responsibility as a standards development entity to comply with federal and state antitrust laws. So if you're speaking or providing written communications, you have to refrain from any discussion which may provide the basis for an inference that they have agreed to take any action relating to prices, services, production, and allocation of markets, or any other matter having a market effect. And just we try to make sure that everyone understands that we really are pretty generous in order to comply with antitrust practices. So adherence to antitrust guidelines means not only avoiding antitrust violations, but avoiding anything or any behavior that might be so construed. This is a basic requirement, again, of our standards development work. Next slide. Brief announcements. Again, looking forward to 2025 is next. Doing our end-to-end review for language barriers and incarceration status. We have a few concepts. And then closing with community homework and next steps. Again, the most important homework is come back to the meeting next week where we have our final vote. Next slide. Announcements. Next slide. There's like one more day to comment on our utility and security IC10 CM submission that we presented at the IC10 Coordination and Maintenance Committee meeting on September 10th. The technical workstream calls are always there's a lot going on there right now as we look forward into 2025 and review everything we did in 2024. Some specific updates very soon. Those meetings are 1 to 2 on Wednesdays, and then we have our final implementation workstream meeting next week, 2:30 to 4 p.m. Eastern Standard Time. Well, we're really lucky to have an informal roundtable with our colleagues in the EHR vendor world, including Oracle, Cerner, and Epic, and we're reaching out to a few more, just because over the course of 2024, sorry, it's been a long day. We've talked a lot about the standards that we develop at Gravity and the regulations that reference them. And we've heard repeated questions about how EHRs are supporting entities in building those standards and referencing those standards. And our friends are going to come and help us understand that. So thank you so much to them. It's going to be a great conversation. Next slide. And then we want to note that for anyone who was there or was not there yesterday, as part of our work to center members and building off of our social care voice co-design work and part of our strategic goals, which were to really again support CBOs in direct provision of care and payment and reporting. We conducted a discovery on payment and reporting standards required to centering the CBO perspective. We presented that report yesterday at the technical workstream in a listening session. We also talked about next steps, and we talked about what terminology was already doing to support the recommendation 1, which is terminology to support CBO payment and reporting activities. The recording is available on the Confluence. You can read the report and you can read the blog about it. Again, really grateful that their synthesis across both the social care voice co-design and our member strategy on making sure that we support social care entities and CBOs in delivery. And again, amazing leadership from our members and CBO voices on that. I think Elena's on the call here. She was one of our member leads. So thank you, Elena. The report's great, and you can read it and read the blog and listen to the recording on the Confluence. Next slide. We wanted to announce, and Mark, thank you for elevating this. The ASTP Health Information Technical Advisory Committee has convened the Health Equity by Design Task Force. We have some Gravity members in that work group, especially like a shout out to our amazing patient advocate, Janice Tufte. I don't know if you're on the call, but we see you there. And the purpose is to provide ASTP with recommendations on promising practices, challenges, and resources to support health and human services organizations to incorporate health equity by design principles into the design, build, implementation, use, and monitoring of HIT. As per all ASTP and high-tech meetings, the convening is public, and we welcome you to come, and there's public questions at the end. And just as we are engaged here, we invite you to be engaged there as well. You all are experts in, in many of these concepts, and your voice is very welcome. So all of the information on the task force is available in the links and further information at ASTP. Next slide. Any questions on the announcements? So the first slide was normal. Second slide was about the payment and reporting use case final report, which is great and can be accessed, again, recording yesterday, and then the Health Equity by Design Task Force. Okay, let's keep going. We have a lot to do. Who are we at Gravity? We are, all of us here, a collaborative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. And again, I always try to make sure, because again, we work from a social justice framework. In addition to most HL7 accelerators, we do have a sponsor member representation on our governance committees, but from a social justice framework and a CBO voice perspective, we ensure that we have designated entities that have very significant roles in our governance, including community-based organizations and patients built in by design. Again, we're very intentional about that to ensure that social care entities, CBOs, and patients are included in the design of the solutions that we endeavor to create. Again, it's been a long day. Yeah, we wouldn't be able to do it without our members, and thank you to these members for supporting us in 2025 as we go forward. Next slide. 2024, we are at the end of 2024. Here we are at the end of November. Next week, closing out our fall terminology domain build, looking forward into 2025. As we mentioned, we had that discovery and payment and reporting discovery and the report and out. We're working on our STU in tech. We're working on our update to align with the US core. Implementation affinity group last meeting is next week. And then we go through our kind of, for terminology and implementation, we go through a public quiet phase until we kick back up in February. More on that when we come back next meeting. We'll tell you the roadmap for 2025. Next slide. Again, just making sure everyone knows, because this is important when you look ahead at 2025, and you already heard me talk about it with the social care, with the payment and reporting use case. So much of what we've done in 2024 has been based off of our really intentional convening of social care entities, human services, community-based organizations across the ecosystem last year to develop our social care voice co-design report. They assisted us in expanding and deepening our use cases to ensure direct care social care entities were voices and priorities were part of our use case design. We've been leveraging that throughout 2024. And we'll continue to do so in 2025. It was really lovely. The report is pretty great and available on the Confluence. And again, it also is what accelerated the inclusion of social care voices in our governance model. So after the co-design, we infused a whole number of new social care entities in our leadership structures to make sure that we kept those principles at heart. Next slide. In that co-design report, you can also see all of the bios, and on the page in the Confluence, you can see all the bios of all the social care entities who were part of that work as well. When we look ahead to 2025, our new domains are person-level topics and discrimination and chronic stress. And again, Mark, hi, you're on the call. It's finally happening. I know you've been an advocate for this domain for a very, very long time, and we are accountable to it, and we're doing it in spring 2025. It was supposed to be fall 2023, I think. And then in the fall, working on neighborhood and built environment concepts, building out of food insecurity and neighborhood safety, food access, and built off of food insecurity and inadequate housing and housing insecurity with food access and neighborhood safety. We also are going to be continuing our work with coding for food on the next domains of reference and continuing to work with the CDC on enhancements to support housing instability and homelessness. And we are presenting to the operating committee on Monday, hoping to center protective factors as within our work as well, because we have mentioned that we were going to address them for a very, very long time. We include protective factor assets when we do any domain through as a proxy through goal development. As we know, social determinants are not just risk-based, they're also protective. Protective factor documentation is a core facet of social work, nursing, all of the work that we do in healthcare on a regular basis, not to mention social care. So hopefully leaning into that in 2025 as well. Next slide. Okay, here we are, 11:14. Last day of end-to-end review. That was the end of the business part. We're now going to get into the topics. Incredibly grateful for all of you. I'm just going to do a quick status check. I know, Kwesi, you're here for incarceration status. Thank you so much. I do not see, I see Eddie is here as well. Hi, Eddie. I just want to make sure I don't see any of the language access concerns. So I'm going to be speaking for language access for our SMEs. Things have been settled there for some time. And then per usual, making sure that any questions are addressed by our SMEs as we go forward into the incarceration concepts. Next slide. All right. Oh, sorry. This is one. Hi. Oh, hi.
I know. Hello.
Hi. Oh, I've missed you. Hi. Julio's lovely. Hi, Julio. Just know, okay, quite a greeting you get on a national call. Sorry. Julio is here. He's one of our brilliant language access reps and a wonderful person. And I haven't seen him for just a couple weeks. So it's nice to have you back, friend. Hi. Before we go into our work, we always try to level set in our principles that we established in 2019. Again, working from a data justice and social justice framework, really critical to address core principles. And these 6 principles are centered in all that we do. Next slide. Next slide. Okay. Just noting that if there are any, we've mentioned this slide before, so because we're working on housing enhancements with CDC, if anything is aligned with that work, I'm highlighting it in purple just so you can see the intersections of what we do. Next slide. There's going to be a page in the Confluence coming soon to collate all that work that we're doing with the CDC. More on that soon. Probably next meeting, we'll have that set for you. For the masters, they're always posted on the Confluence. Coding for Foods under food insecurity, language barriers, and program classification, incarceration status all have their own areas of work. Next slide. Okay, end-to-end review. We know what we're supposed to do. This is our final moment. The point of end-to-end review is to ensure that the work that we've done collectively over the course of the last many months is good. Right? So we sit back and we've been doing this work over the course of the last month, right? There was this early phase, it's all this proliferation and gap addressing, like what do we need to say, figuring out things. And end-to-end review, we sit back and think about it as a whole. And we ask if there's missing concepts, does anything need to be changed? Is something unnecessary and it should be removed? And we're doing this, is what our SMEs are doing right now. And Kwesi can testify. Right now in incarceration status, our SMEs are just looking at everything and saying, is that right? Is it necessary? Does it need to be fixed? Right? So this is the work we're all doing together. If a community member has a suggestion for end-to-end review, a comment, they're all submitted formally because we have done a lot of work together in consensus and community. That work needs to be respected. So if there's something that is an edit, please send it in written form. And then any question Any questions addressed by the SMEs? Lucy, I want to, maybe someone else, I see Corey's here, maybe a technical person can address Lucy's question, because I don't know if I can answer it at this time, but we'll try to get to it, Lucy. Next slide. The vote is next week. So the consensus voting happens via Google poll during our 11/21 meeting. It's an all concept meeting. So, but everything has happened in language, meaning coding for food, and this, because we had to make the deadline for prior to ICD 10-CM. We had the option of making a new meeting just for coding for food, but I think we're going to be okay. What the votes mean, a yes vote does not necessarily mean that the deliverable is the ideal one from the perspective of the committee party, but it's better to move forward than block the deliverable. Yes with comment. Any comment has to be sent to Gravity at hl7.org a week after the vote. Formal objection has to have a vote to be included, and again has to be sent by the same date. And then if it's not, it's an abstain, and abstaining is just abstaining. You always can request an absentee ballot. You just email us and we'll send them to you. And again, we are very forgiving about the voting process. We try to support all of you. Just let us know how we can help. Reach out in advance. Next slide. Thank you, Corey. All right. We're doing language access and then barriers, and there's not a ton of new stuff here, so this shouldn't take a ton of time. And again, Julio, thanks for being here. Next slide. Incredible thanks to our amazing subject matter experts across the ecosystem who've grounded our work. We would not have been able to do it without them. Great thanks to all of them. Experts in class standards, experts in equity, experts in language access, experts in translation. And then we were super grateful again that our friend Lisa came to represent signed languages as we were working toward equity in this domain. Next slide. One thing that's really important, and this is a decision that guided us, is when we are doing this work, our intent is to identify social risks that you can make a care plan on. So early in our work, we identified what those concepts would actually be. Not everything that we were addressing as domains is something that needs to be highlighted and intervened on. So everything in blue are those concepts we elevated. Again, primary language that you speak is not a problem. Right, what we need to lean into is where the system needs to meet the person. We've always been working from from an equity-based lens there. And so this is guided at the terminology we've developed since that time. Next slide. Next slide. So the language barriers, if we go into next slide. The language barriers concepts for English language proficiency are unchanged. So we have two primary concepts there, limited English proficiency, which is the equivalent to limited spoken English proficiency, and limited reading English proficiency, and those have been stable for some time. Next slide. These concepts have also been stable. The concepts for what preferred language is, we have a definition for it, which aligns with federal statute and Joint Commission. It does not, we are still not elevating as a problem. And then we have interpreter needed and sign language interpreter needed and translation needed concepts. Again, those have been pretty stable. Next slide. And again, all of this aligns with class standards, health equity elements, Joint Commission, etc. Next slide. We do just have some concepts that even though we were talking about the concepts on the previous slide, we hadn't pulled forward for your view, the SNOMED concepts that align with them. So we're just pulling them forward because you're going to see them in the master and the final vote. So there's existing concepts for interpreter needed, existing concepts for telephone language interpreter service requirements. We're adding from an equity perspective, requiring in-person language interpretation services and requiring in-person sign language interpretation, again, from an equity lens. And then we are proposing, after talking with our SMEs, an interpreter needed in healthcare setting, IC10-CM concept, more coming to, as we're going to have to convene our ICD wizards on how to address that gap. But when we thought about it very carefully, it was actually our friend, again, Lisa from ACL, the sign language equity expert who identified the need first, and then we reconvened to talk about just that purpose. Next slide. We are going to have a concept for translation needed. There is nothing, no SNOMED equivalent, and we are proposing a possible ICD-10-CM concept for the same. Definitely submitted to SNOMED. And then we will look at ICD-10-CM correlates for the same. Next slide. Screening assessment instruments. There's not a ton because we had pretty strict requirements for what got in. Again, thank you again for our experts for showing the way there. Next slide. So, so for preferred language, any instrument that asks about preferred language for communication within the healthcare setting, and then we had some pretty clear specifications that it had to specify healthcare setting to differentiate from primary language. So the SAMHSA core behavioral and psychosocial data elements question is the one of standard. Hi, Lucy. Yes.
Hi, Sarah. Communication within the healthcare setting. Should we expand this to health and social care setting?
We talked about that for right now, because of the Joint Commission standards, we've been talking about that consistently. Because we're specifying healthcare for now, but we certainly can come back and revisit it in future instances. The reason why we're specifying healthcare is because that's what the regulation support. It is something that we identify, and if there's additional instruments out there that give us room. Again, there's no instrument that says that. There's no instrument that asks that question, but if instruments arise that ask about that, we will certainly go there. But we sorted earlier that we were gonna bind ourselves to healthcare for the specific question, but again, understanding that preferred language is. Hi, Julio. You want to speak?
Yeah, quickly. And I don't think that it's going to get covered during this effort, but I will want to dialogue with you all about this. It's something that we're discussing internally at CDC now that we're standing up an language access policy and plan. And that's this issue of the service recipients agency in selecting their preferred language. From an equity standpoint, my read of the department's regulations, and I saw it in your slides, is that all of our efforts around language access is in the production of and delivery, communicative delivery of information, but not so much in the receipt or satisfaction of the delivery and communication, right? And so I clarified that as a first step, but that first step does not provide cover in terms of those services for people with cognitive disabilities.
Yes.
And so I wanted hopefully for you to confirm that we don't have cover for cognitive disabilities, and that I'm reading it right, because that will be something that we'll need to look into next year. So I'm hoping that maybe we're all on the same page. Over.
We are, thank you, Julio. We are on the same page. We carved out communication access, and within that, disability access and cognitive ability access to language services. And we met with ACL on that specific domain of reference and leaning into it. It's on in our proposed domain sandbox, and we'd love to work with you again. So you're correct that that's not here. Centered, notable, included. Lisa is involved, and we've met with ACL a couple times to make sure that we are going to collaborate on filling those gaps as intently as we did the language one. Go teams. All right. Is that anything else, dear friend?
Thank you.
Okay. All right.
Sarah,
Yes.
Sarah, maybe consider for next year as part of our process. You often show the slide about our total process. Maybe an element needs to be inserted called what we can't do now, or our parking lot, or out of scope for the moment or something so that people coming upon what we do won't ask questions like the one I just did.
I think that's great. What I'll try to do, maybe next time, I love pictures. I'll try to demonstrate all the things that came up when we did this that were carved out as important and unique and separate, but are not addressed in this domain. And because I think every time we do a domain, there's lots of work that happens in the beginning, in the early phases that does just that. So I'll try to do that.
Exactly. Yeah.
Yeah.
But I keep thinking of people coming at this fresh,
Mhm.
and certainly we know a lot of people
Mhm.
have expertise here in these meetings, and they may miss something.
Yeah.
And you could say, that's in our parking lot. Hope you got a chance to look at that.
Great.
Instead of having to explain constantly, we thought a lot about this early on, but we can't do it now. Okay.
I can do that. That sounds good.
Okay. Thank you.
Next slide. Great. And one of the things that I used to do that in call out boxes, but it's difficult to be 508 compliant and do like images. But I think I hear what you're saying. I can do better. All right. So we have core interpreter needed concepts and questions. Again, these have not changed. Next slide. I'm going to try to focus just on new stuff because we have a fair bit to address. We are aligning with US Census. This hasn't changed. Next slide. We did work with the US Census Bureau to get their direct phrasing for how the American Community Survey would be worded with a patient-completed survey as opposed to the administered survey on ACS. Again, we really grateful for the quick response of our friends at the Census Bureau. We've worked with them for some time. Next slide. This is not new. Again, and then we have, for the reading English, even though the Census Bureau doesn't include that concept, the National Latino and Asian American Study is an example of that. And so because our SMEs wanted to center that, we have it here. Again, well-tested, psychometrically valid, not as the gold standard like the Census Bureau, but it's been in existence for some time. Next slide. And then even though we are not addressing primary languages as a specific problem, we did want to elevate best-in-class methods for screening for primary language. Lucy even sent over an amazing version of interpreter needed, which was in primary language statements. So again, not elevating a question that's in English to ask if you need an interpreter from her pharmacy experience in California. So just for the purposes of interest, here's the IPEAK statements about for primary language identification. Next slide. And then we worked really hard to make sure that we included representations of indigenous languages used across North America to the best of our ability. And then here's the sign language I speak version. Next slide. All right, and so here are our goals. And then Julio, I just want to know, even though here, next slide. Part of what you were mentioning regarding quality does come up in our goal statements. I mean, and not the breadth of what's covered in communication access, which is going to be addressed with our partners in ACL from a disability rights perspective, including alternative and augmentative communication types, et cetera, et cetera. But we do pull in as a primary goal statement, effective communication from Joint Commission based with all the references that are included in the ADA. So that is our kind of overarching goal, right? Is effective communication, again, putting the responsibility on the system. And then we're still working on definitions for the other specific concepts regarding interpretation, but receives consistent qualified interpretation in preferred language for healthcare, and timely interpretation, noting that timely is a measure of reference for access in clinical settings. Again, this has not changed. Next slide. Always centering the system, meeting the person. Yay, Julio. All right, programs, professions, and roles. Next slide. No changes here. Again, all of our core, all domain concepts roll over, like every community action agency, every social worker, every community health worker, every AAA, right? All those core programs that are able to help consistently across each of our domains, we always roll that over. So you're not going to be seeing that here because it's just a set of information that goes with every single domain. Next slide. What you are going to see here is the specific callouts, right? So request for language interpretation, request for document translation, and then just noting that we originally had referral concepts for document translation, and as you all are aware, our SMEs asked us to use request for, because the person doesn't go to the translation interpretation comes to the person. Next slide. Okay, very few changes in language access and barriers. The only thing that happened is that some of the codes behind, ICD codes behind the SNOMED concepts came to bear. Thank you. Okay, now we're transitioning into incarceration status. Again, grateful for our SMEs for being on the call to support this. And next slide. Amazing subject matter experts. It's been like a really, like these two domains for me have been like a masterclass in equity, and just cannot be thankful enough for our two subject matter expert groups. It always makes me emotional, this domain, but I'm incredibly grateful for SMEs in helping guide this work. We had experts from DOJ and experts in clinical practice, and just really, you know, making sure that we're always kept our eyes on the prize and centered the patients and the people we're trying to assist in all this work, and always made sure that we were thinking about our principles as we went forward. So thank you so much, SMEs. Again, just brilliant, and it's been a masterclass for me and all of everybody on the Crafty team, and probably all of us together. Next slide. Okay, core concepts. Next slide. I'm going to do a level setting here. So it's important to say this only because I really want to be obvious about what there might be, like what we are able to say now regarding these concepts and what might change over the course of the next week. Throughout the work that we've done on this domain, and very clearly in language access as well, we've highlighted the importance of how concepts are phrased, right? Given our mission to minimize bias and promote health and person-centered care. Our SMEs have been amazing expert in leading us on this, like early considerations of bias and language access, considerations of bias and risk throughout incarceration. One thing that's important to note is that changes in phrasing are very common once we leave this group and start working on modeling and authoring with different standard development organizations like SNOMED, CT, and ICD. We do the best we can to get things in line, and there's always rules of whatever terminology that dictate things. And so given the care that we have taken in figuring out how to say things, there's some things are still how in process. And I'm just asking gentleness in that way, because we always work on how after the fact with trying to have fidelity to what we did in this space. And I just want to give our subject matter experts as much room as possible to keep on figuring out how we're going to present what, so you all know what we're working on conceptually, but there might be tweaks of how between now and next week. And there also might be tweaks after. Because there always are tweaks after, because that's just the nature of modeling with terminologies. But we are so careful in this domain to get the how right. Again, from that minimizing bias, there's going to be bound to be changes after the fact. And I'm just trying to state that up front. Next slide. Does that make sense? Again, we are just being guided by our SMEs in a carefulness exercise, and I just need to keep on centering them in that work, even after the vote next week. Again, no new what's, but how we're saying things might change.
Sarah,
Yeah.
I think one of our implicit principles has always been to be leading edge. And this incarceration status work has really exemplified being leading edge. And we all know that when we try to do new and interesting things, there's going to be structures that don't want or can't or have to think forever about our work. So I think that's what you just said, but I just want to emphasize how innovative this work really is. And we all just have to hope that within our lifetimes, we see ultimate compliance, dare I say, or at least uptake. Thank you.
Thank you, Lucy. Thank you. Okay, so now in the what, we're going to be talking about the what. Slight revisions to our currently incarcerated concepts because we're likely not going to be able to get the not going to be able to get the currently due to structures of authoring in SNOMED. So we reviewed with our SMEs and are taking that off, but everything else is the same. Next slide. And so what you'll see here is representing that in the SNOMED concept, incoming SNOMED CT code, and there's the current ICD-10 code that roughly encapsulates this, right? Our SMEs have reviewed this, and again, it's like an in process, but I wanted to make sure you all saw the concept that exists right now. And you're going to be seeing, again, some existing ICD-10 concepts across these next slides. And it might be that with language access over the course of the next week, our SMEs decide that they want different concepts or slight changes in them. This one's been fairly constant, but across the reentry concepts and in community concepts, it's tricky. And we want to make sure that those, whatever we're doing is again, minimizing bias and ensuring correct representation. So there might be some changes in ICD when we go, when we come back. Next slide. This is an unchanged concept, right? So this is that incarcerated and expected release within 90 days. Again, one of the primary use case here was wanting to ensure we supported the reentry work that's happening across the national ecosystem to support individuals reentering community. And this is a critical concept for that work. Just as we did with some of our, much of the reentry references will underwrite the concepts that we're going to be submitting across ICD and SNOMED. Next slide. These are concepts that we haven't decided to include in our set yet, but they've been, just because our SMEs haven't looked at them specifically, and so I put them here as a to be determined. We have to figure out, there's really only 2 ICD concepts that correlate to identifying concerns once an individual is re-enter community. Z65.2, which is problems related to release from prison, which we know is insufficient because there's not just prison. There's also other forms of incarceration, but we're going to have to, my primary job with the SMEs tomorrow and tonight is to try to lean into these concepts, but I put them in italics here as something that we just know we need to look at.
And Sarah, can I just bring up that
Hey. Yes.
we did brush very briefly on this one, but I think one of the things that stood out was release from prison being the thing that is not actually the problem. The problem is prison. So the release part was one that we had visited recently.
Yeah. Again, just centering our SMEs and determining what needs to be said. Oh, thank you so much, Rada. Next slide. And then SMEs, again, just thinking about what is in process. I mean, what we're trying to represent here, not wanting to miss anything. But the wording might change because we're actively working on this. SMEs are working on final wording for a concept related to solitary confinement. And again, SMEs, please help flesh anything out, but to represent when solitary confinement's relevant to a patient's story and a person's story. And one of the things we've been leaning into is that solitary confinement's driven by different purposes. It can be administrative, it can be protective, it can be disciplinary, and trying to understand how to represent that concept well, again, supporting critical storytelling, but minimizing bias. Anything else to say here, SMEs? Again, wording to come, the how, but the what is something that we're leaning into.
Sarah, this is going to sound very naive, voluntary. Does this imply that a prisoner can ask to be put in solitary confinement?
I'm going to let our SMEs answer that question because they are the experts. Cressy or Rada, do you
Are
already?
you, Lucy, are you referring to and what you have in the chat? Is that the question you're
No,
voicing?
No, no, no,
in the
no.
working definition.
I'm in the working definition here.
Oh, sorry.
Experience of a minimum in carceral facility due to administrative, voluntary, or disciplinary origin. That word voluntary, whereas up above in the bullet, the last line says protective. I read protective meaning that authorities think that someone needs to be protected, so they put them in solitary. The working definition here has this different word, and I was wondering what's going on with this voluntary word.
Thank you for the question, Lucy. So an individual can voluntarily request to be placed in administrative segregation. If they feel that their life
Hmm,
is threatened, they can ask for voluntary status. That
okay,
voluntary status, the individual will be put in a 23-hour isolation space while that person is reviewed to find out whether or not they meet criteria for that administrative segregation. And then when the person's in administrative seg, depending on the state or, yeah, depending on the state or the federal space, they would be in a 23-hour isolated space. However, they may have contact with other people on a gallery, like on a floor, versus if they were in a solitary confinement space without any physical contact, or excuse me, any visual contact. So in some voluntary spaces, you can see a person. In other solitary confinement spaces, it's a solid door. You can see nothing, touch nothing,
right.
hear nothing. So that would be the voluntary space.
Thank you for that. For
I
that
would,
clarification. I guess I would wonder, when someone comes out, the nature of the solitary confinement, is that a factor in their experience?
No matter, well, it's unfair to say that. Yes. I'll just answer it that way, yes.
So do
If
we
it-
need another affected by experience of solitary confinement when voluntary, and then another row would be affected by experience of solitary confinement not voluntary? I'm just wondering
So those are
whether,
some of the things we're thinking through right now. So it's not in, this is,
okay,
yeah, this is partly why we originally just had a simple concept and then we turned it around, and Eddie can speak to this too. Like we started to turn around what stories we wanted to tell, and we're just leaning into it. So the how again, we'll figure out. Like we know we want to lean in again. We know it's terminology when we want to support the SMEs in identifying stories that are critical. And these are the kinds of things we're talking about in our SME meetings. 100%.
okay,
Yeah.
thank you.
Anything else to add, SMEs?
Eddie, you were gonna offer?
yeah, I
Any-
mean, just affirming what you said, right? And the complexity of like how we are thinking through these definitions and the relates to like the health, right, aspect of things. The other thing that that could, would also take us into another conversation is also for those who are struggling with mental health or suicide, right? Like a lot of times it's like involuntary are requesting for support, which means that they would be isolated and separated, right, based on their own will or request. So that's just another area that often doesn't always get talked about, but very similar to what you just pointed out, Josh, as well.
Okay. All right, so more to come here. Oh, Denise, yeah.
Sorry, I have to find, so protective didn't cover what you all just said, because I thought it was protective, like isolation or, sorry to extend, but do you understand my question?
I'm just confused why it didn't, because it's protective to the person, right? Like the
Okay,
person is protected by being in solitary confinement,
the person is protected. Okay, thank you.
their body and self. Was that helpful? And again, wording to
Yes.
happen. And again, the how is sticky right now, and we're
Yes.
working. Yeah.
Yeah,
And
I
again,
was just trying to follow along and I
yeah,
couldn't
yeah.
type
And
it.
my words are the least adept here because as I try to make these slides, so I'm going to make lots
That's
of.
okay. I hooked on phonics. That's how I
Okay,
was taught.
great.
So
Okay,
you're
fantastic.
doing good. If I can
Okay.
ask quick questions, I can keep up. Thank you.
Okay.
Denise, I will offer to you a way maybe to think through or to experience how administrative, protective, disciplinary, voluntary. The media doesn't help us in our understanding of what those things are when they really happen. So all of us in this space, we can spend some time to really think through how those words and phrases really mean when we are actual around them. So some would say there is a famous music mogul in a carceral space right now who was initially administratively segregated to protect the institution, not him.
Oh, okay.
He
And
was,
that's what I'm thinking. Okay.
you see what I'm saying? So
Yeah.
initially it was, we got to protect the institution because you bring too much with you.
Oh,
So if you're in general population,
yeah.
we administratively can't run the organization.
Yes.
Similar to Tupac and initially when
Yeah. Yeah.
Clinton, I was in Clinton when Tupac came. So initially they locked the prison down just for the individual to get in
Yeah.
because we're unsure how to move the person around. From there, it went to a protective space because then
Mhm.
it went to, well, now if we move you out, people are going to try to get at you. So we can't have you there. Then from there, it went to a disciplinary because you got in some trouble. So you can
Yeah.
move through these kind of stages around what that means. And then other people will go into a voluntary space due to contact with an individual and they may not know. So
Gotcha.
if that's
Individual.
helpful for you to
Yeah. Because I can't ask my cousin who works in prisons because he's not supposed to tell me all that. Okay. Thank you.
yes, that's what it is.
Yeah. Okay. Thank you.
Thank you, Steve. Yeah. All right, so more to come on here, but just at this time again, because the vote is next week, just elevating that this is a concept we're leaning into. The reasons why it's taking some time exemplified in the conversation examples that Kwesi and Eddie just gave. Aren't they amazing? All right, next slide. Again, this is and I'm elevating this for me who continues to remind me that this is important and I did not want to exclude it. The wording is coming here, but we are really trying to make sure that we tell unique stories. And I get so emotional. But we're working on wording and I'm trying not to forget that we're working on wording for a concept to represent the unique risks and trauma related to youth incarcerated in adult facilities. We had a proposal. I didn't get it right. So more to come there. Again, it might not make it to the final step, but I would not be responsible to our subject matter experts if I didn't note that this is something we're considering, because it might be there next week. But again, the how is in process, the what is this, because it's a unique story that needs to be told. Elena?
I apologize if this is something that's already been covered, but I am in my kind of quest for data that gets at kind of informal networks and the people we belong to in our communities. From the work I've done in the past, one of the things that I know came up often was talking about how incarceration impacted their informal networks and relationships, and because of a whole host of situations. And I'm wondering if we have any concepts that might be able to help capture the kind of the communal impact of incarceration on individual relationships and ties that make up so much of our stability in our daily lives.
We did lean into that a bit in our legal needs concepts and certainly in our goals. Smeeze, do you want to hold that, or do you want to reply to Elena now, or what do you think? We've been definitely talking about it constantly.
There is a both and, Elena. There's first, thank you for surfacing that to a larger group. That's really important. The second piece is yes, and yes. Yes to the importance of informal networks and how those informal networks inform the clinical space and how we think this through. And this would be, what is the core concept that really tells the story and provides an actionable code for the provider to do something with it. And the second yes is, how are we thoughtful about the language we're going to use to encapsulate that? So yes and yes.
And let's look, maybe, I think we have some good examples of terms, and we'll work with our SMEs with your thought in mind, Elena, over the next days to see if we've addressed it. Yeah.
And to Lucy, to your question, which Rada is answering, our squad here is working all the areas at the same time. Youth, the term youth is always a question. It's such a broad term. And as Rod is pointing to, there will be some legislation that comes around what is youth, what are we defining that as, and how is that informed? And more what I would offer is, how is that trauma informed? If you say youth, is that really a trauma informed way to communicate a human being who's in flux and going through a transitional stage consistently? Their identity formation's happening. To Elena's point, the social network is storming and norming. So how do we think through that? So our hope is we'll get some support to help inform what we're doing.
Again, more to come here, but just want to note, the aim here is always telling stories that matter. So this is one that obviously is compelling, and we'll come back next week on this one. And thank you, Smeeze. And community, for all your questions. All right, I'm going to try to keep us moving, just so I don't think there's a ton more new stuff, but next slide. Oh, there's actually some pretty significant new stuff on the next slides. Next slide. This is a different placeholder. We have settled on reentry as the term to describe the process in which a person's reentering community, the extensive support, like literature there, the use case. We are still exploring limited and essential time boxing. But one of the things that's been happening is, as I mentioned, end-to-end review is a process of asking if what's needed and necessary. We actually are considering winnowing some of our timeframes as we think about the evidence to support timeframes that matter, and really wanting to make sure that we're building what's necessary, so that you're going to see this in process, and I have presenting it in a different way. But the SMEs are deep in that right now, looking at the concepts of reentry, making sure they're naming these touch points that are really critical, and only building concepts that are critical and supported by the literature. Next slide. One new thing that is how to be determined is we've been exploring how important the transition visit is within reentry. There's transition visits across clinical systems, but this particularly the first visit with your healthcare team after you reenter community. We've talked a lot. Again, our SMEs elevated this as something important. We've talked a lot about how no matter what time it occurs, it's important, and it has different meaning almost the farther you get away from the point of a reentering community. So we are leaning into this concept, trying to figure out how to represent. And there's lots of transition precedent in SNOMED, and transitions of care visits are something we call out in clinical literature all the time. Smeeze, do you want to, I think this, yeah?
I'm sorry, in another context, I've become aware within the last year or so of how many people, entrepreneurial type people, think that a visit a virtual visit is just as good as anything else. And in this particular context, I'm wondering whether, as you work on working definition, the idea of in-person could come in so that we don't have, this is an absolute worst case, horrible scenario. We don't have a state contracting with some televisit thing, even outside the United States, which they are going to quote offer, unquote, to re-entry persons as their first visit. I'm sorry if I'm not expressing this
I think you've made
well
yourself
enough,
clear. You're talking
but
about
it just horrifies me that there are people, one of the consequences of the whole AI fad is the idea that we can look at people's records, infer what they need, and then provide a virtual visit to meet that need. And I would hope that that's not going to happen with this population in particular. So I don't know what,
we'll take
okay,
we'll
that's
take
it.
that quality of that encounter and get it and bring it back to the SMEs. And Sue just noting visit is something, yeah, that's a how. Again, this is the first release of this concept. It'll be refined over time. But the how it's represented is definitely something that we'll work on. We
I'm
wanted to
not
get
always understanding the difference between how and what. It says
well,
working
how-
definition here.
the how
To
is
me is-
how
That to
would
me is a what? Okay.
the what? The
Working on a working definition to me is a what? You're defining the thing that, okay. Never
the
mind.
how we
Don't wanna
phrase the
take-
concept. I'm a little confused. It's okay. But the exact words that are in the concept is something I mean by how. But the concept itself as representing the first visit, like the first moment a person encounters the healthcare team, it's okay. We don't have to get too deep into that. But just noting, Sue, yes, noted. We were reflecting on that. Next slide. So in our refinement of in our end-to-end review of critical concepts, one of the things that we're considering is the necessity of that middle 3-month concept. There's a lot of literature supporting the 2 weeks and 12 months. Again, more to come here. But this is where we arrived at our last week, is that maybe that 3-month concept is not critical.
I thought we would change the 2 weeks to 1 month, right, to be inclusive of the 2 weeks.
Oh, my apologies. That might be an error on me. I'm sorry. I don't know if we'd landed that at the end, and we can do that.
I'm sorry. Yeah, that's probably still up in the air. So my apologies.
No, like again, that's totally fair. You're right. And then there was there was a literature bloom at the end of the meeting. But again, the time frame, the concept of reentering is something we know we need to represent. The time frames are things that we're supporting with the literature. And so more on that to come. Next slide. And this is the juvenile facility correlate. Next slide, with the same call out that maybe I messed up the 2 weeks. This slide has not changed. This is the community supervision concept supported and the treatment court concept supported by the amazing resources of All Rise. Next slide. And then we're playing around with wording, and this is like, again, a how thing in my humble definition. We've used the word limiting in the past because affecting can be both beneficial and negative. We'll recenter this with our SMEs, but it's going to be one of those things. And again, this is where, Elena, we had focused on a family and social connection and how histories of incarceration affected those concepts. We pulled that here to tell that story, and we settled on the legal needs concept to align with medical legal partnership, understanding that legal histories are not always negative histories, and that goes back to some origin like 6 weeks ago concepts. Not much change here. Next slide. All right. Okay, so screening instruments, nothing new here because there are none. Next slide. We're not having any instruments for screening because of the lack of evidence of screening for incarceration histories in clinical settings and our concern about bias. I do want to note our subject matter experts and are actively initiating research to understand individuals' perceptions on being screened for histories of incarceration. So research coming. And so again, this is another example of how we asked a question in a good place and some great people are setting off to get us information. Next slide. Goals. Next slide. Again, those connections concepts are coming in heavy here. Next slide. Again, these are all existing concepts. Really lovely conversations about goals and trying to support health and within our subject matter experts. And so we have these concepts. I think we had these last time. Self-efficacy, satisfaction with job, training equivalence, again, pulled from past domains, social connection concepts in the bottom there. Next slide. And again, these are all concepts that Gravity built before. Same thing here. We have a continuing of our social connection concepts. Again, Elena built off that the problem statement we identified earlier. And then all across our financial security concepts. And this goes back to that evidence that Eddie was speaking to at our kickoff, right? The increased rates of food insecurity and housing instability and homelessness, and really trying to lean in. And that's, again, part of the why. It's like making sure that we wrap around individuals and support them. Yes. Next slide. And then we have these ones I think actually these are new. So we have income sufficient to meet needs, has access to transportation, hopeful for the future, feeling more empowered and confident and able to maintain self-esteem. And then we have these are ones again that already exist in SNOMED. SNOMED is heavily populated by nursing care plan and goal statements. And so that's a lot of the literature, a lot of the concepts that we see here is nursing concepts for nursing care plans. Next slide. And then we lead into the literature there are problem statements. We have concepts that don't exist, representing family reunification, accessing peer support, self-determination. And then I don't know, Kwesi, if you want to go into self-determination theory since you're such an expert. But and then demonstrating self-management and feeling affirmed in your health goals by the care team, which is something that can apply to every domain, right? So this is just another example of a domain calling out concepts that are critical for whole person care. But self-determination theory has been a key facet in our work. Anything to say there, Kwesi, on that, or
Not unless anybody
has any questions? I think
has any questions on it.
there's lots of beautiful literature on self-determination theory out there. Okay.
Self-determination theory can ground the biopsychosocial spiritual model in a way. And since self-determination theory is in the literature, it's grounded in much of what we do in care. It's a nice way to scaffold what we're doing. It'd be the most easy way I can.
That's great. That's perfect. Thank you, Chrissy. Thanks for being there. All right, next slide. So now we're going into programs, professions, and goals. And I actually don't think there's any new programs here. So our biggest development were the to be determined concepts in diagnoses and goal statements. Next slide. Okay, again, those all domain references are really critical, calling out the legal ones that we've built in the past as well. And then we're going to just elevate the ones that are specific for this domain. Next slide. We have, again, unchanged, community-based reentry, veteran justice outreach program, halfway house. Next slide. Forensic peer support, prison doula program, and parenting while incarcerated program. Next slide. And again, these are all themed, grouped. Recovery housing, and our first building of community mental health center, and which is also known as a designated agency. We talked about themes a lot, but it's a critical, health and mental health access component. I want to thank our friends at DOJ for constantly advocating for mental health access in our SME meetings. Next slide. Then we have critical programs. We always try to pull in references from our federal human services entities. So Administration of Children and Families programs have been an incredible source of program references across our domains. They were just significant in utility and security. They were our definition for community action agency, the definition for medical legal partnership, right? We always lean on additional human services definitions when we do our work. So we have family reunification, family strengthening concepts. And then last time we pulled for the Transitions Clinic program, which Lucy, when you were talking about problems with quality of visits, it made me think about this because like best in class is what a transition clinic offers, right? Which is care and peer support, which is the antithesis of being a number and being unseen, right? So that's partly why we the SME is elevated to include this best in class example of how to support individuals. Next slide. We have doulas. Because we can't, when it comes to a refer to concept, we can refer to programs. So we have that the prison doula program as a program because it has a definition. But when we refer to people and professions, it has to be grounded in the National Uniform Claim Committee, Healthcare Provider Taxonomy. So we have refer to doula. Next slide. Doulas. And then we put this here only because we present the programs, and as all of you know, we wrap all of these programs in the syntax, right? Counseling about, education about X program, refer to X program, evaluation of eligibility for blank, right? So the syntax for interventions framework wraps around all those program statements and professions and roles, and then you get our end concept. All right. There are, so this is an instance, Lucy, where I acknowledge the brilliance of deaf doulas. We are bound in this instance to the NUCC profession, and what we do advocate with our colleagues at NUCC for additions of critical social care voices, like housing navigator, for example. Is something that we are working on. So just note that if we ever note a gap in gravity on a critical social care role, a community role that we always try to work with NUCC to get it represented. We presented to them 6 weeks ago, something like that, on gaps and opportunities there. So right now we're bound to what we can say of the NUCC, and we always advocate. Next slide. I think that's it. Wow. All right. So it is 5:13. At this time, we've addressed, again, this is a sequential intercept model, which has grounded a lot of our work. So we've reviewed all of the concepts that you would see when it comes to the vote next week. Again, wording on some of those concepts is going to change. Again, like some of the wording that was offered in the chat is a lot of what we do in our meetings, and it's a lot of what we do internally, and it's a lot of what we do with authoring in the terminologies. Any questions on language access or language barriers concepts before next week? No.
I wanted to just reconfirm about the screening question. So is it right now, it's going to be limited of what's being asked? Is there going to be any question about just issues regarding legal involvement in general to see if, let's say, somebody has they're involved in like a custody situation and it may or may not be related to incarceration or charges of
Yes.
Child abuse. So like just, I guess, not screening for if you have or have not been incarcerated, but screening to see if there's any legal involvement situations that they're actively.
Yeah, so we carved that out as a separate domain. Again, here, Lucy, I need that sheet. Right. So we support the medical legal partnership. I help screening methodology, which screens for health related legal needs, right? And do imagine circling back for legal needs in general to make sure we elevate that and support that in being encoded. Absolutely. That's where we got our problem statements from, was the medical legal partnership approach. And we plan to circle back around on that 100%.
Okay, perfect. Thanks.
Yeah. Any other questions? Okay, next slide. We're quickly going to go just to all domain concepts, and we have some concepts that we're submitting as part of our CDC housing insecurity and housing instability and homelessness work, and gaps we've noted in our program classification. So I'm just going to go through and also all social care gaps. Okay, next slide. So this is just gaps that we found when we were looking at, those core helpers and roles in the community that assist with social needs and social risks across the ecosystem. So these ones are not new again. Next slide. We just don't add them to our value sets until you've seen them. Oh, and then, the housing concepts will come probably next cycle. Come back for the vote next week. Again, SMEs, thank you so much for your expertise and your guidance. Community, thank you for this process, right? This is our final end-to-end review moment, and we will see you next week for the meeting. If you need an absentee ballot, send an email, and we will make sure we get you one. Jonathan, yeah?
I just want to make sure, are people going to be celebrating Thanksgiving? Are you meeting on Thanksgiving?
No, that's why we have an early vote next week.
No, I just wanted to make sure. I thought the vote was this week, so I just wanted to make sure I didn't miss anything. Thank you.
Oh yeah, you did not. No, we have an asynchronous meeting next week, which is a week early, so as to not convene individuals at Thanksgiving. And I know my house will be filled. All my aunties are coming per usual, and I have a lot of aunties. So I will not be able to host a public call because I will be up to my gizzards, literally.
Well, and you deserve a break. So.
Thanks. Yes, I get to, even my daughter's bringing friends from college, which is just the best. Like, fill up the house. All right, so next week is the vote. And then, but if we have a week after the vote, always the public vote, we have an absentee ballot timeframe. Any other questions? Thanks so much, friends. Again, we've done pretty powerful work over the course of the last months. Our SMEs have guided us through really critical concepts, and it's just been an honor to do this work with all of you, and thank you. Thank you for being with us in this work, and I will see some of you next week in the implementation affinity meeting, and I will see SMEs tonight and tomorrow. And I'll see you all back here next week for the vote. And again, thanks, and have a lovely evening.
Thanks, Sarah.
Thank you, Sarah.